All right, let's get started. We're right at 12 o'clock. Just to again, make sure everyone can hear me, correct? Perfect. All right, so this is going to be just like Dr. Carroll mentioned. It's going to be pretty rapid fire. I don't think any of the interns have seen a presentation from me so far. So one thing to know is I usually have a lot of slides. I'm not going to just read off the slides because you'll have access to this after, so you can go through more in depth as necessary. I'm going to really try and hit just the key points that are important, but this is a talk that I first gave to the nursing students, and then I realized, we usually give this every year to you all. Dr. Murphy does a great job. She gave it last year, but I wanted to just do something, hopefully to help you out. I think it's going to be important, especially on the inpatient side, because we want you all to look at the slides. So hopefully it will give you an idea of how to at least approach these, and then just over practice, you'll get an idea of, or get at least more comfortable. So some of the objectives, really try and stay awake, especially, well, I think if it was at 2 o'clock, it'd be a little harder, but shouldn't be too bad. We're going to go over a systematic approach on really how to approach these, just like EKGs, CTs, all that kind of stuff. If you have a systematic approach, it's going to be a lot easier to make sure you don't miss things. And then I'll have some areas at the very end about things you just don't want to miss. When you're in the ICU, we're looking more for tubes, lines, et cetera, like that. But even like peritoneum or neuroperitoneum, we've had it come in overnight. So at night when you're on your own, be sure you don't miss that kind of thing. And the pneumothorax, especially in the ICU, or after you've done like a thoracentesis, those are the kind of times where it's a high risk. So when you're going after a chest x-ray, we're going to really do that systematic approach. We went over on rounds a few days ago, if not yesterday, but there's different approaches and styles to it. I like the alphabetical approach just because it's really easy. It helps you make sure you don't miss anything, right? So we're going to go through each one of these in nauseam, and I apologize, but I really wanted to make a very in-depth lecture so you can go back to this whenever you want. But before we kind of go into it, let's just do the very bare bone basics, because I know we have a medical student that's rotating up with us on Team B, so I don't know if he's in here or not, but just in case, any for the residents, interns too, just knowing that, obviously the air is going to be black and then metal is white, so anywhere between that is where we're going to have these different densities. Hounsfield units is really used for more CT, and so we don't really use that term for X-ray or radiographic imaging, but just knowing what these different intensities can help distinguish different things. So if we were to look at air, which we know is black, you're going to expect to see that here in the lungs, right? And then obviously on the outside of the body. But then as you kind of get closer and closer to white, you're going to be seeing, the fat. It's going to be a little harder to see. So this is a thin person, just the next tissue in, and then go into the soft tissue, and then obviously into the bone, where we're going to be talking about that on its own, making sure we don't miss any fractures. And then finally metal. So someone like this that obviously is wearing a necklace, don't really recommend that when you're getting an x-ray done, because you could obviously miss something that, if you had really bad odds, it could be right there. So obviously try and get all those things off the patient if possible. All right, so just looking at it in general, we have the bone here, we have air here, and we have water, fluid, blood in the heart. So it kind of gives you an idea of how these different densities can be put together to help us even sometimes diagnose. There's something called the silhouette effect, where you can sometimes find like an underlying pneumonia, which I might have an image on. I was reading about it last night, but we'll go in depth. So let's first orient ourselves anatomically, because if you really don't know the anatomy, it's going to be very hard for you to be able to distinguish where things are or what you're looking at. So we have the trachea at the top, and then we know that branches off into the right and left main bronchi. We have the aortic knuckle, which is on that top left side. I'm going to say left for the radiographic left for the patient. So if it throws you off, just know that I'm talking about radiographic wise. And the carina, that's important, especially in the ICU when you're intubating someone. You're trying to get 3 to 5 centimeters from that carina. And then obviously the diaphragms comes important when we're looking for fusions, even COPD, et cetera. The aortic knuckle we'll talk about as well, in terms of where masses can sometimes hide in this area. So we like to see that there is not outpouching, or there's no other, that there's no other evidence of a mass that might be hiding behind there, which will help us out if we're getting like a lateral film. And then this came up on rounds, I think 2 days ago, or maybe yesterday. Sometimes you'll have a pericardial fat pad that can hang out in this area. So if you see kind of like here it is, but if you don't see a crisp line, it doesn't necessarily mean there's an effusion. It doesn't mean that there isn't one, though. There could be, but a lot of times it's just some fat in the heart. And then if you want to get very rudimentary, you just have the clavicles at the top, the heart stuff in the middle, kind of important, I guess, and then the diaphragm and the liver. But if you're looking at a lateral view, which we don't really get a lot of chance to do because, most of our patients are just going to get portables because of just ease and it's not less for the nursing perspective. Then you can split up the mediastinum into 3 different sections, and I'll get to that later when we're looking at the great vessel section, because if you remember from medical school, we divide the mediastinum and that area into 3 different areas that can affect our differential diagnosis, like thymomas, lymphomas, stuff like that. So it's just important to know, in the heart, it's going to be really in that anterior aspect. You want to see that there's a nice retrosternal clear space. This is what they're talking about, this area. When you don't have that, then you're worried maybe there's a pericardial fusion. And then those 5 T's, which we'll go over later. And then the middle, you have the esophagus, the aorta is there with the trachea, and in the back you have, vertebral column. I'll go back real quick because we're going to talk about later, knowing that typically that vertebral column, you want it to be white, and then it's going to eventually become clear. If you see that it's white and it doesn't ever become clear, or if it goes white, clear, and then white again, there could be a pneumonia that's hiding here that you might not necessarily see on that PA view. Let's try this. There we go. So I have a lot of different images that might portray the same thing, but as with most of my lectures, I try and use different ones because some people might help to see one view, whereas with others, they might kind of get better idea or understanding of a topic by looking at a second one. So a lot of this is the same information. I'm not going to go over it here because you'll be able to look at this later. So let's start with that step-by-step approach. So the way I organize this PowerPoint is at the top left, you're going to see basically a table of contents. So you can see where we're at any time. So we're going to start at the assessment. It's the correct patient, the correct time, are they rotated? We're going to go through the most important ones of those now. So first, let's look at these vertebral bodies. This is going to help us. So I'm going to try and see if I can hide something real quick. There we go. So we're going to look at the vertebral bodies here. We're going to make sure that they appear to be center. If they're off to one side, so maybe the vertebral body appears to be here versus on this side with that spinous process, then maybe they're a little rotated. And we're going to use the clavicular heads as well to help us decide if they're rotated. But we're going to get more in depth on those in a second. Projection, is this a PA or an AP? We've talked about this on rounds again, but when we're looking at the x-rays in ICU, they're typically going to be portable, which means that the heart is not going to be necessarily as close to its true anatomic size as you would see in an AP. And the way I kind of described it to the interns and the residents was, if you have a projector, when we used to do lectures in person, which seems like it was a long time ago, but you put your hand close to that projector bulb, your hand is going to look very large on the screen behind it. Whereas if you put your hand close to the screen and farthest away from the bulb, it's going to be the shadow that it casts is going to look true to its anatomic size. So that AP view is going to be as if you were to, or the AP is as if you were to put your hand towards the bulb, and the PA and the lat is going to be as if you put your hand towards the screen. What you need to know is, again, it's just going to affect the size of the heart. So if you really are looking to call cardiomegaly or so, you're probably not going to be able to with confidence. But if you saw concurrent effusions or maybe some pulmonary congestion, it might increase your suspicion that's truly what's going on. So if we were to look at how on one of the same patients, how it might look different, that PA on the left side is going to be the one that's more true to size, right? So the PA lat, and then you can see how much larger the heart appears when you're doing the AP or portable view. And when you're looking at the size of the heart, I just take my index finger and my fifth finger, I put them on either corner of the heart, literally on the screen itself. And then I slowly rotate it, or shift it, I should say, to the right or to the left. And I just make sure it's not greater than the width of one side of the lung. So if I were to do that, and unfortunately I can't, I kind of want to try drawing, but I think I'm going to screw it up if I don't, so I won't. But if you were to do that on the screen as you're watching this presentation, you can see that the heart on the left doesn't look like it breaks that 50% mark. But if you were to do the heart on the right side, you can see that maybe it gets a little closer for comfort. Okay. Again, just another view. Try to be a little technical with the animations, but this computer really can't handle it, I think. So you can see that the heart just appears to be a different size. And again, that pericardial fat appears here. But again, you don't want to just assume it's that. You might want to get a lateral view just to make sure there's nothing hiding back there. And as I talked about earlier, you use those the clavicular heads to kind of help you decide if there's a rotation. So you can see that there is a little rotation here because that left clavicular head is closer to the midline than the right clavicular head. So the only thing that would cause that is if the patient is rotated to the right or not. So this might require you to physically, put your fingers on your clavicular heads right now as we're talking. And then if you were to turn your head or rotate your entire body to one side, you would see how one of the clavicular heads will now appear more in line or more in center than the other. So use those clavicular heads and the spinous processes to kind of help decide if that patient's rotated. So here, I tried to draw out the outlines of the spinous processes in the clavicular head. So you can see this patient's probably a little rotated to the left side. And then again, that left clavicular head is so far off from the center, whereas the right is very close. So this patient, again, is probably rotated to the left side. Any questions so far? We're not even halfway or 25% in, but I thought I'd ask. Yeah, I'm going to give you like 2 seconds to respond. So if you don't, then I'm going to keep going. Good. All right. So now let's go into penetration. So we have the perfect penetration here. We have over-penetrated and under-penetrated. So if it's over, it's just going to appear darker. Under-penetrated, it's going to appear black, gray. I'm sorry, but this is kind of more of the boring stuff, but we have to get through it because there's no way you're going to truly understand how to carry on to the lung field, et cetera. But what you need to just know big time, or the baseline, is if you can see the spinous processes right through the esophagus, everything's through there, and you can just see them, that's a perfect penetration. If you really can't, or so here you wouldn't be able to, they're completely whited out. And then here it's probably a little too much, but you can just get an idea in general. Okay, it looks like it's pretty much gray, and I can see the spinous processes, that's a perfect penetration. This is going to be important really when you're in the ICU and you're doing a chest x-ray after you put in a tube and or a line, and you're trying to just make sure that everything looks okay, because you don't want to send them away, the radiology tech, and then have them to come right back. Let me see if I can. Okay, well, somehow I hid my views for you guys to ask me questions. So I don't know if I'm going to be able to see if you ask me questions. Oh, I didn't mean to do that. Oh, well, all right. Now let's go into the inspiration. So we talked about this as well in rounds, just knowing that anterior ribs are going to be coming up and then down, as if you were to put your hands in your pockets on the front. And the posterior ribs in the blue are going to be the ones that kind of look like a little sunrise. In general, if you just remember there's number 8, for the most part, if you can count 8 ribs on either one of those, you're pretty much going to be good. All right. And the reason why it's important is because if someone has not taken a deep breath in or out, if they took a very short, shallow breath, then you might have a lot of lung tissue and alveoli that are kind of collapsing on themselves, and you might get higher readings of atelectasis, so there might be the presence of maybe a developing infection or infectious process, is what the radiologists like to write. So on the right side, you can see this is a good inspiratory effort. You can see some of the spinous processes were on the left side. They just did not. And so you see a lot of haziness here. There could be some pleural plaques or some masses here on the side, maybe from like asbestosis, silicosis, et cetera, that you might miss because of the inappropriate penetration. And then finally, we're going to look at the trachea. You're going to look for any midline shift. You want to miss like a thymoma or even like a thyroid mass that could be affecting that. And if obviously tension pneumos can cause it to shift over, and we'll have some images of that as well. So again, you're just going to use those spinous processes, the clavicular heads, just to make sure there's no obvious shift. Something as subtle as this, it might be a little overkill from our end to call it, but if the radiologist was really detailed and they want to call that there's potential, I would say this is probably more of a shift in the rotation true than actual deviation of the trachea. And I have some pretty wicked images of true tracheal deviation. And then the carina, as I kind of mentioned, that's where you'll have the separation into the right and left bronchi. And just know that you want to be about 3 to 5 centimeters from the carina when you're putting in your endotracheal tube to make sure it's deep enough, because if it goes past the carina, most likely it's going to go onto this right side, right? Because that left side, well, I don't know what happened there. Let me see. Oh, there we go. Because if it goes onto that right side, it's more of a steep drop, whereas in the left, it's a little more up in like 90 degrees. So you're more likely to hit the endotracheal tube and then realize you're too far, whereas going onto the right side, it's a lot easier to just keep going and not realize until you're, completely at the end of the endotracheal tube at the teeth. So here you can see there's clearly some mass that's probably not going to be associated with any kind of calcium deposition, or would show up. That's probably causing some deviation on this chest x-ray. So we talked about the carina. I think I zoomed in here to kind of show you where the carina is clearly at this point. You can see kind of somewhat of a little X here, or a triangle, and then the endotracheal tube went a little too far on that one. And then finally, bones. You don't want to miss obvious fractures. So we're going to look at the ribs as much as we can. Some of the vertebral bodies, you can sometimes see many evidence of osteoporosis based on the changes in that calcium. Looking at the clavicular heads, making sure you don't miss any clavicular fractures, obviously in the right clinical scenario. So kind of in this patient, there seems to be something wrong right here, right? So it looks like they have bilateral clavicular fractures. I think I put arrows, yeah. But see as much as you can of the humeral head, but that's obviously not going to be a necessity for repeating x-ray if you can't see the entire arms, because for the most part, people are told to hold their arms over their head or at least off to the side. All we care about truly is the lungs. And then you obviously don't want to miss, going back, fracture. So this looks like it's a mass, but in reality, this is an old rib fracture that when it healed, it forms a callus and then it shows up as what might look like a mass. So you might want to get a lateral and then see if you see anything on that end. Or if this was a smoker, you might consider, getting a CT if they are in the right window for getting screening CTs. Yeah, I completely lost how to get you guys on my presentation. So if you're asking questions, I cannot see them, so I apologize. And let me see if I can at least go back on this. Okay, so, sorry. I think this computer, I'm using one of the hospital computers and it is going really slow for me. Okay, so we've done assessment, airways, bones. We've now we're really getting into the meat and potatoes of how to look at some of these lungs. So now we're going to look at the heart, and we're going to, again, as I talked about and hinted at before, looking at the enlarged size. And it appears to be that yellow area of labeled A appears to be more than 50% of the blue line, which is B, especially in PA lat. Then you're suggesting, hey, maybe there is some enlargement. You might look for, if there's no effusions on either side, and maybe there's no increased pulmonary congestion, which is overt heart failure, you might say, well, maybe there's a pericardial effusion. Maybe I'm going to look at their blood pressures and see if there's an association or change with inspiratory effort. Maybe I'll look at the clinical history and say, and find out, does the patient have any trauma to the chest, or maybe they have an EKG that shows some low voltage. So I'm thinking about an infiltrative process. So that's why something as simple as a chest X-ray might lead you to going down from an internal medicine route, looking for a lot of other pathology. And then when you look at the mediastinum here, I included that under cardiac, but I'll get to it again under great vessels, because that's where we really look at the chest. You can see that enlargement like this, can happen with asbestosis. Same here and even here. So again, on this side, you can actually see some outline as well. Looks like it was a superior vena cava that was a little deviated. So there's probably something right in the middle, and it could be, a thyroid. And then looking at the schizophrenic angles, some of these questions, because I don't have much time to present, I'm not going to wait. But if I had more time, and maybe if I could have some restraint and not provide you guys with 80 lecture slide PowerPoints, I'd have time to ask. But obviously the schizophrenic angles, we're looking for effusions that are developing there, and you can use that lateral film to kind of help as well. But we're going to look at the schizophrenic angle here as well. Remember, I talked about that pericardial fat pad, which can sometimes mask an effusion developing. And then you're going to look at the right side, the left side, and then if you see associated pulmonary congestion, which in my opinion is kind of the hardest thing to overdiagnose for us, since we're just not as experienced. But if you see like a constellation of an enlarged heart, maybe some fluid, and maybe some stuff here, I might say, yeah, this is maybe suggestive of heart failure. Now we go into the diaphragm. So I kind of labeled them two different colors, so you can see, if you can hear that tinging in the background, I think some patients upset about their food. But yeah, on the right side, you can see there's a yellow, and then I highlighted on the left, or the right picture itself. The blue I just put as the gastric bubble, so you can just see how the diaphragms from the left and the right appear different. And then when they're flattened, we might see that in someone that has heart failure. So you can see some flattening on the right, on both sides. And again, on the right side, it might be higher naturally in someone because of the liver, or someone has known cirrhosis and liver enlargement. You might expect to see that right liver is enlarged, or that right diaphragm is a little higher than the left. And if someone has had a cardiac bypass, and you'll start seeing a lot of, the actual instrumentation, the post-surgical changes with the clips in the center of the mediastinum, it's not uncommon to have fluid just on the left side. It's very common right after the surgery, and it can last for a month or so after the surgery. So you might see that if you see some of these cardiac patients that are coming out in the ICU after a CABG. But then one thing you want to look for is making sure that you're not missing some obvious air as well that's hiding under the diaphragm, right? So you're going to have two different lobes of the diaphragm. We're going to see some air that sometimes can hide up under there, that there's some pneumoperitoneum. All right. And then edges of fusion, it's really kind of a catch-all because we already kind of talked about with the cosophrenic angle, and we can see this is an obvious effusion here on that right side, a complete loss of the cosophrenic angle, whereas on the left side we have a nice one. And the way I kind of describe it is if you were to take your finger and physically put it under the image of this cosophrenic angle on the patient's left side, it would look as though it's so sharp it could cut your finger or point and hurt your finger. Whereas if it's dull and kind of blunted out, then it tells you if it doesn't look like it would theoretically hurt, then maybe there's some fluid that's hiding there. So again, here is now an effusion on the left side, maybe lack of one on the right side, but it's getting very close to potentially cutting off this right lung. So if I were to get this at the bedside, I might ask to see if they could potentially reshoot this film. And here it might not be as obvious, but if you were to use that little finger test like I was telling you, where you put your finger under, it looks like it would not hurt at all. It's way too blunted and soft. So you can see on both sides, bilateral. Here you can see the heart, if this was a portable, which it appears that it is, it's way beyond 50% the size of the lung field. So you'd be seeing, okay, maybe an enlarged heart with bilateral effusion. This is probably suggestive, and you can see some streaking interstitial opacities here. It's probably suggestive of some heart failure. All right, so this is the big stuff, right? So the actual lung fields, which we don't want to just jump to. We still want to do the A, B, C, D, E up to this point, but the lung field is where a lot of the stuff kind of comes together from a pulmonary standpoint. So I put these images over to kind of show you where the right middle lobes would be versus the right upper lobe. And the big thing to realize is that right lower lobe is maybe not as high up as we might think. So if I were to go back, it's not going to be as simple as cutting these areas just in 3 pieces, but the lower lobe is actually going to be, I tried to stretch it out as much as I could, but it's pretty much going to be down here. So the right portion of the heart here is going to capture really the right middle lobe. So if you see something down here, it would be more consistent with the right middle lobe pneumonia. All right, and this is the anatomy. We're not going to go into that, but just to give you an idea of how I like this image because it shows you the pulmonary vasculature on the left side versus on the right side. It shows you the actual bronchial anatomy, and that's why it's going to be so hard. I know one of the hardest things for me is like, is this alveolar, is this interstitial, et cetera, et cetera. We'll get into that, but that's why it can be so hard because you have such diffuse anatomy in the lungs. But there's different ways you can approach the lung fields themselves. I normally do the this right image where you're kind of zigzagging all the way across. There's no right way of doing it, to be honest with you, as long as you capture the whole thing. Some people just do one side at a time. There's no problem with that. So let's go into the differential. So if we're looking at the alveolar versus the interstitial patterns, what's the big thing to know? The alveolar is going to look very fluffy. It's going to look like clouds. It's going to also be radiolucent, and there's not going to be very good margins on there. And when these cloudy, fluffy pieces somewhat come together, then you're going to see them merge together, creating these kind of shadow appearances, whereas the interstitium is going to be made up of really your vessels, lymphatics. It's going to be more radiodense. It's not going to be able to be seen through, like we'd be able to see our spinous process through that center like I talked to you about in terms of the penetration. And the interstitium, that's the scaffolding that supports everything, whereas the alveolar walls themselves and the actual areas of air penetration and movement is going to be more your alveoli, right? So the interstitial patterns will be things like nodules. It's going to show up as lines, dots, maybe lines and dots, whereas the alveoli, just remember, fluffy. So we're going to go through this a lot because, again, this is your first presentation with me for the interns, but you'll see that I like to repeat things a lot. So you kind of, one of them will hopefully stick. So you can see the consolidation, which is clearly going to be radiodense. You might have masses versus nodules, which we'll, I think, touch on just a little based on their size. But the interstitium, you're looking for more lines, lines or dots, whereas the atelectasis or the alveolar processes, you're looking for something that's like very hazy. All right, so the pulmonary markings are going to be, again, the more visible interstitial, so think those lines, whereas, and it might even be nodular in appearance, whereas if you see something that's very hazy, cloudy, it's going to be more of an alveoli. Why does that matter? Well, it affects your differential diagnosis, which we'll have in the next few slides, but it also just helps you when you're trying to describe what you're seeing on rounds. You can say this looks like more of an alveolar process, or versus this looks like more of an interstitial process. And then going back to this slide, you know, if it's going to be greater than 3 centimeters, then we're going to call it a mass. If it's going to be less than that, we're going to call it a nodule. And that's going to affect, obviously, the risk for cancer, the likelihood of cancer. I don't like not being, oh, there we go. I was going to say, I don't like not being able to see the chat room. And okay, now I can see it somehow. All right, sorry about that. It was just kind of weird because I feel like I'm presenting to myself. But so let's look at the alveolar infiltrates. So now we see that we can have, you know, again, pus, water, the blood cells. Those are all the things that would cause that fluffy type appearance to show up on a chest X-ray that we would consider to be more of an alveolar process. If it's pus, we're going to call it pneumonia. You know, water, edema with our heart failure patients, and then cells, it could be potentially blood. So here you can see this is a very fluffy, you know, type presentation all over. So we're going to call this more of an alveolar type process. And it's going to be radiolucent, so we can really see through it. You know, so you can see even the ribs, you can see the back of the lungs here. So it's not completely whited out like you might see here in the center. And again, as I mentioned before, the differential is going to include one of these 3 things primarily, because we're talking about the actual alveolar sacs themselves. Here's a better picture that kind of shows the patient, again, more of a fluffy. It kind of reminds me if you're studying for the optometry section on your boards, they'll talk about the cotton wool hemorrhages and things that you can see on your optometry or ophthalmologic exam. So this is going to be more of the appearance that the alveoli are going to have. Again, fluffy, white, radiolucent. But if we go into the interstitial patterns, there's a huge differential. I'm not going to go into these, but I liked this table and the way they described it and broke it up at least. So I wanted to put it in here so you guys would have it for your slides. And we're going to go, unfortunately, I'm sorry, through each one of these pretty in depth. So again, interstitial, it's going to be either linear, reticular, which is not really linear, but it's like curved appearance, or nodular, which is just a bunch of dots, or basically a bunch of all of those, a reticular nodule. And if you remember the interstitial process, that's going to be that scaffolding, the things that make up the, you know, the lymphatics, the blood vessels, et cetera. And it's going to be something that's going to be more radiodense. So if we start with what would a linear type interstitial pattern look like, it would be here. So we can see these streaking lines that go all the way out. And so this might be someone that has, you know, underlying interstitial pulmonary fibrosis. You know, sometimes you might see this appearance in your heart failure patients with the curly B lines. So looking for the streaking white lines when you're looking for a linear pattern. And then the curly B lines, which again, we know we see that pathognomonic for our heart failure patients. Here, surprisingly, you know, they don't have significant effusions. Heart doesn't, this looks like it's a PA lat, doesn't look too enlarged, but you still see these lines completely going out. And again, you're seeing me talk about how far they're going out, because the farther they're going out, the less likelihood that's a normal variant. Because you might see some patients that have some congestion in the center area, and you're like, oh my gosh, that has to be some pulmonary congestion, but that's just how that patient is. But you won't see these streaks going all the way out. Or if they have a pneumothorax, you might see them completely stop and then a black appearance. But the fact that you see these lines out here is more suggestive of an interstitial process. And again, here's some lines going all the way out. So in this one, I just wanted to kind of show you, when looking at your patients with heart failure, you're really going to look at the top and the bottom, because you shouldn't see a unilateral or a one-sided extension of these lines. So at the top, I wouldn't expect there to be extensions, whereas in the bottom, you know, I wouldn't. So when you see them on both sides, that it's more suggestive this is true. And you can see how massive this heart is. So multiple things kind of pointing towards heart failure. All right. And then a reticular pattern. So, so let me go back, sorry. They're going to be either fine or coarse. So you know, again, these kind of wavy type presentations where it is still lines, so maybe just not as straight. This is very in-depth. You know, I don't think from an internal medicine perspective, I would honestly feel comfortable being able to say, oh, that looks more reticular than anything, or fine versus coarse reticular. But you know, if the radiologist comments on that, I put the differential down here where it might help you kind of lead towards a different diagnosis. But you can see the difference here from a coarse perspective. So I'm going to let you take like a mental snapshot of it, and then I'm going to go back, and you can see how it's just not as obvious, whereas this is just all over. And it doesn't look really like an ARDS type picture, because we're not seeing it all the way out, but we're seeing it kind of centrally located on both sides. So this would be, you know, underlying emphysema, or like a really bad pulmonary fibrosis, maybe someone that's on chronic oxygen, multiple hospitalizations for exacerbations on chronic steroids, et cetera. So if you just have an idea, I think really of being able to differentiate the reticular or interstitial versus alveolar, you'll be good. But if you want to get more in depth here, there's more of a nodular appearance. So kind of here, 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 maybe as well. But you can imagine how it's just kind of hard to really distinguish. But I just want to show you as many different x-rays as I could that really show more of a nodular interstitial pattern. And this is a very fine nodule. So you can see it looks like it's more secondary to poor, like the photo itself is maybe just grainy, but no, this is the actual chest x-ray with very fine nodules. And I might be thinking of like a miliary TB in the differential in the right clinical scenario. And then if you were to take all these, you know, the reticular, the nodules, the wavy lines, the nodules, the bumps, if you want to call it that, for lack of better terms, and put it all together, you can see that, you know, this is how it would appear. So you have small little fine lines kind of coming up, but then you have these big nodules here as well that present. So again, just showing you different views of it. And if we were to put them to get all three like next side by side, I know these aren't the best x-rays. I just tried to find as many as I could again, but I want to put them all three side by side so you could really see the difference. So reticular, there's going to be a lot of lines. If it's nodular, it's going to be just a bunch of dots, but not really lines. And then the two together, it's going to be obviously dots and lines, all part of interstitial pattern. The pulmonary vasculature or framework, if you want to call it that, it's going to be radiodense, not going to be as easy to see through these, okay? I'm going to get past that one. Okay, and then here you can see this is pretty obvious, especially unilateral, so not much here. But then here you see a large, what appears to be mass, you know, greater than 3 centimeters. On this side, there's obviously nothing here, and you can compare the two to see, okay, it looks like there's something on that right side. Maybe I'm going to get a CT chest for a better clarification. So if we were to look at the lung field again, if you recall, I talked about how that right upper lung kind of goes this far deep, and then the right middle encompasses the right heart border, and then the lower lobe, or the right lower lobe, is going to be down here. So we had called this really in the right upper lobe. So I'm going to go back, and you can kind of see it seems to follow that fissure. Okay. And then again here, a very good classic view of that straight fissure line showing that there's a clear delineation of that right upper lobe. Here it looks like this is on that right heart border, so I'd probably call this more of a right middle lobe. And then an abscess, you see that halo effect. Sometimes you see that halo effect being described on CTs of the chest, you know, for aspergillosis or obviously some type of fungal infection. But, you know, this patient, again, right clinical scenario, you might want to put antibiotics on, look for fevers, get blood cultures, et cetera. And I'm going to skip that one. And here, I put this here to show you, this is obviously in the same patient, how something can hide actually in that right lower to middle lobe. So in this region, so here's part of the liver kind of coming through, so it gives you anatomically where we're at. So we have to be pretty much right around here. And this spot, which I described as that pericardial fat pad, I said, don't always assume that that's what it is. And this was hiding on this patient's CT when they did more imaging of that, okay? So there's here's the right heart border, the left heart border, some pulmonary congestion. You can see overall that chest, or the cardiac size just appears massive in comparison, regardless of this being a PA versus a LAT, or AP or PA. With maybe some increased congestion, you see these streaking lines coming all the way out. So it looks overall that this was, and it's, you know, pretty translucent. So maybe an alveolar type process. And with that enlarged heart, I'd probably say this was heart failure exacerbation. So in this one, this is a patient, you can see the trachea. If you have probably your eyes and your face directly, like as close to the monitor as possible, you can faintly see the carina right here. So you can tell that based on the spinous processes, it's been pushed out. So there's some mass here, as well as the radiograph sign where they put the arrows. So there's clearly probably a small cell cancer going on. And this one, I will wait. So if you guys can type, what do you think is going on in this chest x-ray? Just one diagnosis. Yeah, so I think that was Hannah and Mathew. So yeah, it looks like there's a pneumothorax going on. You can see that there's clearly some lung markings extending all the way across, whereas there's absolutely nothing on this left side. There's some deviation, it looks like you could call that, because the heart's kind of in the middle, but you might want to go off the blood pressures to kind of see if there's true treacle or actual tension pathology going on with this. And in here, so this is a smoker, but in this person, you can tell that, yeah, so Mafuz was asking if the trachea appeared midline, and it absolutely does. And that's what I was saying, you could see if they have, low blood pressures, et cetera, but I probably wouldn't worry too much about tension pathology because the heart, yeah, most patients, people, we think about it showing up onto the left side, but we know for the most part, especially with Dr. Duffy and how much he's been teaching us with ultrasounds, that the heart is really in that center. So this probably doesn't look like there's probably true tension pathology going on. Thanks, Mafuz. And then this person's a smoker. We can see a large, inspiratory effort, probably a lot more than 8 of those ribs, whether it's the anterior. So here's the posterior ribs coming through here, and then the anterior coming here. So yeah, Mafuz, this would be a COPD-er. So now let's look, I talked about the pleural opacity. So I talked about how if you have a lot of that haziness, that alveolar type presentation, that fluffiness on that either side of the pleura, you might miss, asbestosis, silicosis, et cetera. So I wanted to put this table in here to kind of show you, and you see solitary versus multiple or bilateral opacities that are pleural in nature, what might be going on. So here's an example of someone who has pleural plaques from asbestosis. You can see all these little white things kind of hugging the border all the way along here. So this is something that is definitely fair game for your boards. They just love asking you about pleural plaques. If you hear that term, the first thing you should think of is asbestosis, all right? And it's because, especially the fact that it's multiple. So I talked about solitary versus the multiple. So you're going to think of asbestosis when you're seeing multiple plaques there. And then here we can see that there's more pleural plaques showing up around that side. Very faint, so it might help with the clinical picture. Someone who it's an old, war vet who's been exposed, or maybe they're living. I know a lot of the old barracks, unfortunately, still do have asbestos. One of the wings that for our aviation unit was eventually condemned, and they had to tear it down. So I had soldiers coming up to me on almost a daily basis. Oh my gosh, do I have asbestos? Do I have asbestos? And I told them, I was like, you probably do. And I'll document something. But I told them, unfortunately, you're not going to know for probably about 10 years. But I was kind of joking with them. But I said, there's still, the reason I bring that up is there are still some old buildings that are present and available, or still being used, I should say, that continue to have asbestos, which was used for insulation. So in this one, if it's unilateral, so we're not seeing much of the areas involved on the right side, but on the left side, if you see a solitary kind of unilateral plaques, we're thinking more of like tuberculosis, empyema, maybe even some hemorrhage. So this is a really cool photo showing the overlying of the heart, but I'm going to get very in depth with it, so I'm just going to skip past that. So on this right side, I'm just going to skip back. So I just want to show you this X-ray. You'll see that the left atrium is going to be more towards the top right side of the heart. And then you're going to get into the right ventricle. So it's going to be the majority towards the front of our chest. And again, as we know from those ultrasound presentations and demonstrations that happened from Dr. Duffy, we know that it's easier to see that right ventricle closer to the front of the heart. And then towards the back, so if we were to cut out this blue area, behind it's going to be this left ventricle. And then we'll have the left atrium even behind this area if we were to cut out that green. So let's start off with a normal chest X-ray, and let's kind of add on to it, because what we're going to eventually get to is this. So if we were to start with that normal X-ray, we're going to add our superior vena cava. So this is where it would appear on the chest X-ray with the inferior vena cava. And then we're going to add the right atrium with the tricuspid valve. And then we're going to add the right ventricle, so you can kind of see how we're progressing. And then we're going to add the pulmonary arteries, so the main right and left. And then we're going to get, there we go. Then we're going to get into the left atrium. So you can see how some of the left atrial, part of the left atrium, you have some veins that are coming in from the lungs, and how they can extend out and cause some of what we just generically call, pulmonary congestion. But you can get an idea of how it might allow you to decide, is this really coming from the left side of the heart, or maybe the right side from pulmonary hypertension versus maybe just an incompetent mitral valve. And then if we're adding that right ventricle with the aortic valve, we can add the aorta completely and then see how it's going to branch off and then go all the way down. And then this aortic knob, which we'll talk about in a second, to make sure there's nothing missing there, causing some mediastinal widening. And that's pretty much it. So if we were to, I'll go all the way back, but I don't know if this computer's going to explode from me doing that. There we go. So you can see how putting it all together, again, a 3D structure on a 2D image, it gives you more appreciation of where certain pathology might be able to be localized by utilizing an image such as this. Sorry, let me just scroll through all this. Okay, so let's get to the aortopulmonary window. So it's this one area that I talked about on the right or the patient's left side where you just don't, things can kind of hide there. So usually there's going to be somewhat of an indent. It's actually kind of right here. So if it seems to be flat all the way down, or as if it looks like you could just slide on a sled all the way down that side of the heart without hitting bumps, you might be a little concerned, right? So this is the same as this area on that image that I showed on a previous slide. So here's an example where we do have an outpouching, right? So again, I'm showing you that same image. And that outpouching can be present and localized right here. So again, you wanted to have the nice retrocardiac clear space, and we're just not seeing that. And here's another presentation of a patient that had a mass here. Now, it's hard to localize. You know, could it be part of the aorta? It could be behind it, potentially. But, you know, I think utilizing a CT would probably be the next option, you know, in someone who's hemodynamically stable. But again, you can see some of that mass showing up on the lateral. So in these patients, again, when you see it, it might be beneficial to actually get a lateral, not just going off the portable. And then if you want to get really extreme with that pericardial fat pad that I talked about, where I said you can see some masses hiding, well, this is one that you'd probably be able to say, I don't think that's just fat from the heart. And you can tell that when they did a CT of this patient, they saw this enlarged mass on that right side of the lower portion of the right lower lobe into the right middle lobe. So if you're looking at that knob, and again, it looks like it's either flat, or I guess in this situation, you're getting a bump, but then you're sliding all the way down. It's not coming inward. Then you're worried about aortic pathology. So if a patient comes in, you know, tearing chest pain radiating to the back, that could help you localize that too. Here's another presentation of a dissection probably involving the ascending portion of the aorta as well as the descending. But if you're looking at the mediastinum in general, there's going to be a huge differential, right? So I showed you probably in the third or fourth slides how we divided it anterior, middle, and posterior. And we have those 5 T's that we had to memorize, you know, in medical school. So here's where they start talking about the T's, the thymoma, lymphoma, or terrible lymphoma was the T. So I just put this in here for some of the interns that might be taking their step 3 to have that in there. But it will be a nice chart to potentially have when you see some pathology going on in the mediastinum. And then we're at the last one, so the hilum. So the hilum is the very end. This is where we think of potato nodes, you know, the sarcoidosis, but there's a lot more that can happen. So this green area just represents what the hilum truly is. And if you have it on both sides, you know, the sarcoidosis, which you know about, even TB, not necessarily going to be just in the upper lobes of the lung. You know, obviously tumors is something you don't want to miss, but if it's on one side, it could still be TB or tumor, but it's unlikely now going to be sarcoidosis. The classic board question will be an African-American, usually it's going to be a female who's going to have that, and they'll probably give you an elevated calcium level, et cetera. So hilum here, I'll be honest with you, I think it takes a lot of time of seeing a lot of normals, just like it might be the same with EKGs before you start noticing something that just seems a little off. But here, it looks honestly like the shape of a guitar pick. But you can see this enlargement, and it appears somewhat bilateral, so it kind of helps limit the differential. Here again, you can see bilateral. It appears more radiopaque than in a normal patient that you might have here. So here you can just see how it stands out a little more. So again, you might have sarcoidosis in your differential. And now let's get into tubes. So this is the last thing. You just want to miss any iatrogenic things that we have put into the patient themselves. So again, you're going to be looking for that carina, because we know that at that point where it branches into the right and left main bronchi, that's the part about 3 to 5 centimeters away that we want that endotracheal tube to end. So in this patient, it's really hard to see. You can see the endotracheal tube seems to end right around here. I cannot even see the carina, to be honest with you, but it looks like it might be in this area. So I'm going to take my mouse away for those of you who are looking at it. You can see that it seems to be somewhat close. And then here I outlined it to make it a little easier, but you could see that the endotracheal tube's here, and then the carina, they're a little rotated. It appears to be to the left. So you take from this initial point of the carina itself, and then you measure up to the top, and then just make sure it's about 3 to 5 centimeters. Here you can see that the carina seems to be ending right around here, but it's hard to really tell, but it looks like this is overall kind of branching off to the right side. But If you have any doubts, you could ask to find out how far it is from the nurse in terms of where it is at the teeth is what they'll document, and just see if it's changed over time. So if we were to zoom in, you can see how it starts to branch off a little to the right side. So maybe it could be in the right main stem. And again, something that would help is just auscultate, because if you don't hear breath sounds on the left side, that might help distinguish after intubation if it's been right main stem intubation. And then don't forget about your GI anatomy, right? So I know Mathew wants to go into GI, so I'm sure you were waiting for me to talk about this, but you have that gastric bubble here. We can try and look for tortuous dilated portions of the colon that might show up too. So in someone, just know that the GI anatomy is really going to come into play in our chest x-rays when we're putting in like NG tubes, PEG tubes, etc. So if we were to focus on the GI anatomy itself, we know that the stomach's going to come. We're going to get past that pyloric sphincter, depending on what type of tube we're placing. You might get into the duodenum, or we might stay, if we're just doing an NG, we might just stay in the stomach itself. So just knowing, again, going back, knowing what that anatomy looks like, then when we go to the chest x-ray, we can decide if that tube looks like it's appropriately placed. So if we have an NG tube, looks like it's going all the way down, past where the bronchus would be. So it's clearly not going to be in the lungs. It has to be in the, esophageal portion. And then it seems to come all the way up, gets right into that gastric bubble, and then it stops. So it's a great placement for an NG tube. And this one, we can see that it went off. It seems to kind of branch off, goes to the right, and then and goes back into the stomach. So that's good. But in this one, it went up, never actually made its way down like we'd expect to come up and into this gastric bubble. It went, and then it hit something, went back on itself, and then it went to the right side. So it looks like it went into actually the right main stem. But then you can also have a Dobhoff, going past that pylorus. So you would expect, if you're to follow this line all the way down, that it's going to go past the pyloric sphincter, which is probably, based on that anatomy picture I showed you here, and then it's going to go into that first portion, that duodenum. And you can use, let me go back. You can use this radiopaque marker to kind of help distinguish where that line is. But here, unfortunately, it was misplaced, and it looks like, again, it didn't ever make its way down to the stomach, which would be where my cursor is kind of going, but instead it went off to the right side. So this one went into the right main stem. And then you guys are going to be doing central lines, right? So we want it to be in the caval-atrial junction. So the superior vena cava is where that first part of the term caval-atrial, and then the second part is the atrium. So the caval-atrial junction is going to be kind of right in this area, right in this area. So this is where we'd want that central line to end. So you can see a central line was right on the right side, went all the way down, and it looks like it's pretty good. There's not going to be too specific. I'll show you what you're basically looking for not to happen. This is what you don't want to happen. So this is the PIC line. So this is actually a good one. They start on the left side of the arm, went all the way across, and then ends in the superior vena cava. But, I must have taken it out, sorry. In an attempt to limit my slides to only, I think, 84, I must have taken it out, but I thought I might come back to it. But there's lines where you might have that go right up the neck. I've seen it before, or maybe it goes down, and then instead of continuing to go down, it goes off to the left side. Here's some of those badness that you don't want to miss, free air under the diaphragm, pneumoperitoneum. And then the pneumothorax is the same image from before that Hannah and Mathew had commented on. And then in this patient, the only thing that seems to be off is, it seems to be a little over-penetrated. And then we can see some well-defined silicone implants here. So why did I put this in here? Because it can really inhibit your ability to find pneumonias or underlying masses. So patients that have silicone implants, then you definitely want to consider getting a lateral on them, so you're not going to be missing something that might not show up because of the placement of those implants. So this is a checklist. Again, I'll give you guys this PowerPoint, so you'll have it so you can print it out, but it goes, for the most part, it's not necessarily line by or alphabetical, but it goes through all the major things that you need to do, and you can print it off on a piece of paper and just have. And it's pretty in-depth. It'll even give you the numbers for the masses versus nodules. So that's just there to have. So in summary, I know I went through a lot of stuff, but as with most of my PowerPoints, what I wanted is to have something you could go back to later on and to be thorough. So you shouldn't have to utilize hopefully too many other resources that kind of supplement this, but really just try and get that systematic approach, use the A, B, C, D, E, F, G, H, to try and make sure you're not missing anything. And if you really understand that normal anatomy, and that's why I tried to put some overlying pictures to show you what the anatomy looks like, it's going to help you find some of those abnormalities, especially when you're looking in those hilar regions. And really try and review all imaging. Don't just look at the radiology reports. It's easy in Meditech because they literally have a link directly to that image. So try and bring them up, read them, review them on rounds. If you have questions, our radiologists, as Pat had mentioned yesterday, are very welcoming to asking questions and going over imaging. I've done it multiple times with them. So try and utilize their knowledge base to try and get better at radiology films. And that should be it. Any questions from you all? All right, thank you everyone. I appreciate the kind words. And this should be the only lecture PowerPoint presentation we have today. So I think the first quiz will not be for about 3 weeks. I will send out a calendar information for you all. Dr. Duffy will be doing the first 2 blocks of quizzes. So I'll send that out so you know exactly what's going to be on it. I'm not going to do pages. I'm going to go off of the actual titles or chapters. So then if you're using just the online resource, it'll be easier for you to know exactly what the quiz content is going to encompass. I'm going to be doing the didactics for this year, so please give me feedback on a rolling basis so I know what changes we need to do, what's working, what's not working. But I think I can speak on all the attendings' behalf on saying that we're excited to teach you all. And so if there's specific topics that you want, please reach out to us. So that will conclude the presentation. I hope you all have a great rest of your day.